All right. Good afternoon, everyone. It is 1 p.m. on the East Coast of the U.S., so it is Eastern time. My name is Jacob Christensen, and I'm happy to welcome our in-person and online audience to today's presentation. Today's talk will be the last presentation of 2025, but rest assured, we have an exciting lineup of speakers on the docket for the spring. And I want to specifically alert you to the first talk of 2026, which will be given by Dr. Camilla Vanislau from the University of South Carolina School of Medicine on January 9th. Today, however, it gives me great pleasure to welcome Dr. Dan Mirman. Dr. Mirman is Professor of Brain and Language at the University of Edinburgh, where his research examines the cognitive and neural systems that support language processing, with a current focus on real-world language use, such as comprehending and extending narrative, connected speech, and functional communication in aphasia, and neuroaesthetics of poetry. And today, he'll share some of his work on moving towards clinically relevant lesion-symptom mapping. Please feel free to write your questions in the chat during his presentation for Dr. Merman to answer at the end of his talk. And with that, I'll give the floor over to you, Dan.
Thank you. It's a great pleasure to be here, tell you about some of the work that we've been doing. And I want to talk about my efforts to try to do more clinically relevant work. This goes back to about 15 years ago when I started working on aphasia, and my office was next door to Myrna Schwartz, an absolutely brilliant colleague. And the thing that she was very kind and very generous, and equally extremely smart and unafraid to ask hard questions. One of the questions that she asked me I still think about a lot is, are you doing this because you're interested in aphasia or because you want to use aphasia as a preparation? If you haven't encountered that usage of the word, it means like a biological sample that's been specially treated or processed for experimental purposes, right? So the idea is that aphasia is sort of a context where you can do some basic science research. And at the time that she asked me this question, my answer was very much as a preparation. I'll give you an example of the kind of research I'm talking about here, right? So left inferior frontal gyrus or ventrolateral prefrontal cortex is important for managing lexicosemantic competitors. So lots of people had shown this before, so Jenny Rod, Sharon Thompson-Schill, Beth Jeffries, lots of others. And so from that follows a very straightforward prediction that individuals with LIFG damage should have particular trouble when there's strong lexicosemantic competitors. Okay, so that's sort of a basic science, basic cognitive neuroscience prediction that we can test with people with aphasia as a preparation. So this is the experiment that we ran. We had pictures like this, which when we present them to participants, some people say branch or stig or twig. And then if we ask a different group of people whether those words mean the same thing or not, they generally say they mean the same thing. So what that means is that when you're looking at this picture and you're trying to name it, you have some words to choose among that are sort of equivalent. They're semantically equivalent, but they're different words. So you just have to do lexical selection. On the other hand, you might have a picture like this, where we ask people, what is this? Some people say jam, some people say jelly. We ask a different group of people whether jam and jelly are the same. They say they're not, in fact, quite the same. So in a situation like this, you've got two very similar objects. Right? There's other stuff like this, turtle and tortoise. They're not the same animal, but they're very similar. And so when people are doing this, they have to do lexical and semantic selection. So we have these kinds of pictures. We also have pictures that are sort of unambiguous. We present them to participants, younger and older adults. You get slower responses when there's competition. That's sort of straightforward, as you might expect. And it's even slower when there's both lexical and semantic competition. So we have sort of this evidence that both kinds of competition are going on, takes time to resolve them. Older adults are a bit slower than younger adults. also not surprising. And they're particularly slower when you have both lexical and semantic competition going on. Okay, so we get this, there's two main effects and an interaction here. Okay, so the prediction here, so this is all setting up the study with people with aphasia, is that, okay, we're going to get two groups, some that have frontal damage, including IFG, some that don't. And the expectation is a pattern kind of like this, where you have particularly worse performance under competition for people with IFG damage. That is not what we observed. We have a main effective condition, so these participants are susceptible to the competition, but both groups are equally susceptible to it. There's no significant difference between the groups and no interaction with the competition condition. Okay. So an experiment like this, it's sort of a spanner in the works of the IFG semantic competition story. It influenced how I think about what IFG is doing during language processing. It does not have very much to say about aphasia or treating aphasia or any of the kind of real world concerns of people with aphasia. But maybe it's interesting for cognitive neuroscientists. So coming back to this question, what I came to realize is, that there's a sort of traditional metaphor of a translational pipeline, that if we can understand how the brain works, how language is implemented in the brain well enough, then somebody else can take that knowledge and apply it to solving real world problems. And I started to feel like there's not really any movement along this pipeline. So I started looking for a different metaphor. And around this time, I sort of stumbled onto this idea of Pasteur's quadrant. And the idea here is, instead of thinking of it as a single pipeline where there's basic science on one end and applied research on the other, you can think of it as two dimensions. And there's a dimension of whether you're answering a fundamental question. That's sort of what we try to do in basic science. So questions like, what is IFG doing? How is semantic knowledge represented in the brain? These are fundamental questions in cognitive neuroscience. We can try to ask those. There's another dimension of whether you're addressing a real world problem. And the idea of Pasteur's quadrant is to try to do both of these at the same time. So you're doing basic science, you're trying to answer fundamental questions that are motivated by a real world problem. Okay. So when I started shifting away from thinking in terms of a translational pipeline and thinking in terms of this sort of Pasteur's quadrant idea, I asked myself, what real world problem do I think am I motivated by? Am I trying to do basic research that addresses? And one thought was lesion-based prediction. Okay, so there's a real world problem of aphasia outcomes are quite variable. It's quite hard to predict what kind of, some people recover quite a lot, some people don't. We might be able to use lesion data to make better predictions. And I, as a sort of basic cognitive neuroscientist, might have something useful to add to this effort. So here's a study relatively recently that was led by Chris Sperber, where we tried to do this kind of lesion-based prediction. This is a quite large data set, about 750 stroke survivors, all different kinds of stroke. And what we compared was a simple, essentially regression model based on lesion size, so just how big is the stroke, versus much more sophisticated machine learning models that use voxel level data about the spatial distribution of the lesion. We try to do prediction of stroke severity or functional outcomes. So these are quite variable kinds of strokes, very diverse kinds of strokes. So we're looking at kind of overall measures of severity. So if we look at the NIH stroke scale, we can account for about a third of the variance using just lesion size. We can account for slightly more with a sophisticated spatial distribution model, get 4% more of variance accounted for. that is not a lot. Just in case there's any ambiguity about that. If we try to think in a more kind of discrete terms of good or poor outcome according to the modified ranking scale, they're basically identical, about 62, 63% accurate prediction whether someone's going to have a good or poor outcome. So this was, depending on how you look at it, this is a disappointing outcome for machine learning models or a very positive outcome for simple models of lesion size, because what they're saying is, okay, because we can estimate lesion size quite readily. So maybe that's a good thing. I was hoping it would do better, but actually wasn't super surprised because a few years earlier, Melissa T and I had done a study where we tried to, it was less clever design, but we were also trying to predict outcomes from lesion data. And what we had found was that if you're trying to, so this is just left hemisphere stroke. These are just people with aphasia. We're trying to predict the severity of their aphasia. And what we had found is that if you're dealing with relatively general measures, so something like picture naming accuracy or the AQ, aphasia severity score, lesion size gets you most of the way there, and actually almost as high proportion of variance accounted for as we had seen with in that Sperber study. And lesion location doesn't really add anything. This is, again, lesion location in the context of people who had left hemisphere, middle cerebral artery strokes. So everyone here has got aphasia. But for much more precise measures, so things like speech production or speech recognition, we do actually get significant effects of lesion location and not so much of lesion size. So what we had concluded is that if you're dealing with a measure or a deficit that corresponds to a specific subcomponent or neural system within language processing, then lesion location can be a really useful predictor. But if you're talking about overall deficit, it's pretty much size of stroke. It's really doing most of the work for you. In a more data-driven study, another PhD student who worked with me, John Landrigan, had used a method called community detection analysis. And what he found was that people with aphasia sort of could be roughly grouped into three categories based on the pattern of deficit. So people with mild aphasia, people with primarily phonological deficits, and people with primarily semantic deficits. And so then we asked, can we predict these deficits from lesion patterns, right? Using the same logic that, well, if these align better with the underlying components of language, then maybe we can get better prediction. And for comparison, we used more sort of traditional ways of categorizing people with aphasia. There's the WAB categories, but the WAB categories, there's a lot of them, and it's harder to do prediction when there's a lot of categories. So we also had a simpler version where we used WAB fluency, and we divided people into three groups. So mild aphasia, that's be essentially anomic aphasia, fluent aphasias, and non-fluent aphasias. And what we found was you get substantially better prediction using a random forest model to when you're trying to predict these mild phonological or semantic deficits compared to the kind of fluent, non-fluent deficits. So the upshot of this effort to do lesion-based prediction for me was that lesion size does most of the prediction work. And it is, to my mind, surprisingly difficult to improve on it, even really with sophisticated neural measures, that most of the time it just comes down to big strokes or worse. Within that, if you're talking about subdomains or primary systems, as I tend to think of it, things like speech perception or phonological versus semantic deficits, these are more predictable from lesion location than broad impairment measures like severity or naming that involve lots of different systems working together. In thinking about this, if it's primary systems or subcomponents that are more predictable from lesion location, what are the components that we would want to be able to predict, right? Because maybe it's not phonology and semantics that people with aphasia actually care about, like the real world problem. Like I think from a cognitive neuroscience perspective, being able to predict phonological deficits is pretty cool, but I don't know that people with aphasia care that much about that particular thing. I think what they care about more is things like fluency and discourse, being able to communicate in more real world contexts. So we went about trying to address this. Just to be clear, lots of other people work on these. Lots of other people work on prediction as well. Lots of people working on fluency and discourse. And I was sort of entering this space, trying to learn from people who'd been working on it much longer than I have. Where we started was looking at storytelling as a type of fluency. So we ask people with aphasia to tell the Cinderella story. It's sort of open-ended, but we also know what story they're trying to tell, so we can sort of evaluate it for accuracy or sort of know what they're trying to say. And we used quantitative production analysis. So this is the approach to quantifying the structure. A lot of it's quite syntactic. So a lot of it is about the sentence structure that people are using. And in addition to those measures, we added what I think about as anchors. So these are measures where we know what they're capturing. So things like severity, picture naming ability or word production ability, semantic and phonological ability that we knew from other work, from our prior work, that these are important subcomponents. And we did a principal components analysis. So the value of these anchors in a PCA is that if you know that certain things are important, they serve, as the term suggests, as anchors. And now these QPA measures can combine with them, because if they're correlated, into components. So it provides some structure to the PCA that you're doing. But if they're not strongly correlated with these anchors, then they'll form their own component. What we found was that there was a general factor related to aphasia severity and naming, and including things like sentence length and grammatical complexity. There was another factor for lexical syntax. So these are sort of word level deficits that are related to that manifest in specific words or usage of specific words, like pronouns or prepositions, articles, things like that. Those are all closed class words, and usage of verbs tends to group with this. And the idea is that these are words that are strongly context specific and largely serve syntactic roles. Verbs obviously serve content roles as well. But the closed class words and pronouns largely serve syntactic roles. And to my surprise and slight disappointment, phonology and semantics were separate factors. So these more fluency-related measures did not strongly correlate with phonological or semantic deficits. When we did the lesion-symptom mapping analysis, what we found was, sort of not surprisingly, the complexity factor was kind of a general dorsal middle cerebral artery territory deficit, very similar to what we would see for just a severity measure. It's not surprising because they're strongly correlated behaviorally, so they sort of almost necessarily have the same lesion correlate. For lexical syntax, we found kind of a somewhat, I consider, odd frontal parietal areas. They're not areas that are associated with syntax. Our best guess here is that these are control systems that come into play to facilitate production of these sort of semantically light words that don't carry a lot of meaning, but are very context specific, or their meaning is very context sensitive. That's our best guess. I don't have a strong claim about why that was the result. But we certainly did not see a sort of specific area associated with grammatical structure or fluency. From thinking about fluency in terms of sort of speed and grammatical structure, we moved to thinking about it in terms of informativeness. And here we used an approach called correct information unit analysis. And the idea here is to basically just count the informative words in connected speech. And you elicit the speech in a variety of different ways. And so the idea here is that we're not going to be worried about the production of grammatical structure, but we are just going to look at how much information people are putting out. That's sort of the quantity of CIUs. We can look at the speed in CIUs per minute, and we can look at efficiency measures, but I'll come back to those in a minute because it turns out they behave a little bit differently. First thing, we found quite high consistency across prompts. So we used 10 different prompts from 3 different sort of types. So you can have like personal or procedural information where the question is the whole prompt. You could have picture descriptions. People would be familiar with this, just like the picnic scene and the cookie theft picture, like those kinds of things. And then picture sequence descriptions. So there's slightly different, or there's somewhat different contexts, and they're different individual prompts. And people will produce different amounts of speech depending on the prompt. But what we found is that people who produce a lot for one tend to produce a lot for another one. There's quite high consistency across them. On average, the correlations were around 0.75, and all of them were sort of in the moderate range. And then, again, not surprisingly, or as we keep finding, there's a moderate correlation with lesion size. But on top of that correlation with lesion size, we do see substantial effects of frontal white matter. So that's the anterior arcuate and the frontal aslant tract. Damage there is associated with less informative speech in terms of quantity and speed. And we found this across 3 different analyses, sort of converging to this frontal white matter being important for information quantity and speed. So we had done, at this point, we had done some work with the grammatical structure with QPA, and then we had also done some work with informativeness. We wanted to try to combine these in a way where we were using sort of unique information about sort of fluency and informativeness. So we took 2 measures of each type. We used the efficiency measure, so percent CIUs and the number of non-CIUs. So we think about that efficiency in the sense of all the verbal output that an individual is producing, how much of it is correct information, either in terms of percentage or in terms of the number of irrelevant stuff that they're producing. That's on the informativeness side. On the other side, we have words per minute. It's pretty straightforward. Speed measure, CIUs per minute are strongly correlated, so it doesn't really matter which one you use. And sentence length, so that's again a sort of an amount of output measure. And what we found across those 4 measures is that you can group people into sort of 4 clusters. The interesting thing here was to what extent we can, or again, trying to think in terms of what is the stuff that we're trying to predict, what would be useful to predict. So we thought maybe these clusters are useful to try to predict from lesion data. So that was our next step, is if we have this sort of clustering of behavioral profiles, can we predict which profile someone's going to have based on the pattern of their lesion? And what we found is that we could do pretty well on predicting fluent versus non-fluent clusters. Those are among the informative ones, you get about 77% correct. And among the uninformative, those like more severely impaired clusters, we get 85% correct. Okay, so we can do pretty well at predicting whether someone's going to be fluent or non-fluent based on the pattern of their damage, their lesion. But when we try to predict whether it's informative or not informative speech in terms of efficiency, among the less fluent people, right? So these are folks who are having difficulty with verbal production. They have relatively low words per minute, relatively short sentences. But some of them are producing relatively high proportions of information and low proportion of non-informative stuff. And some of them are sort of the opposite pattern, okay? If we try to predict that, we're not different from chance. The 36% correct here is not different from chance. So what we think is going on here is that in the context of a non-fluent impairment where speech production is difficult, whether someone is able to produce mostly correct information might be more strategic than it is neurological. Okay, so that we cannot predict it from the pattern of damage suggests that it's something other than just where their damage happened. And so maybe it's actually a strategic thing. Right. So what we had found in our series of fluency and discourse work was that length and complexity is quite closely related to severity. Informativeness in terms of quantity and speed depends on frontal white matter. And that this kind of fluency is predictable from lesion location, but information efficiency is not. And so it might suggest strategic differences. And it was here that I started thinking about functional communication and the strategies people use to communicate. I won't have a lot of our data to speak to this because this is our new direction, but I want to say a little bit about why I think this is an important and difficult problem to work on. So for most of the past 20 years of research for me, I've been working at the word level, like that very first study that I talked about, like lexical access, semantic structure, those kinds of problems. And the motivation for that kind of work for me, and I think for a lot of people in the field, has been these kinds of statements. Words are building blocks of verbal communication. Anomia is a pervasive symptom in aphasia. I think certainly the second statement is just factually true. I think the first one is a little bit more of a philosophical assertion. But I don't think either one of those comments are terribly controversial. And this kind of thinking leads us to trying to treat word retrieval or anomia. So here's an example of that from a study that I think is particularly good. This is not my work. This is work from the Pittsburgh group. I think I saw Will Hula's name in the group here. So he might recognize this study. Really nice work, quite large study using semantic feature analysis. So I think a lot of folks here will be familiar with it. It's a commonly used treatment for word retrieval deficits. And lots of evidence that it works quite well. This, I think, is a particularly nice study showing an effect for treated words as well as untreated generalization items, better naming after treatment than at baseline. Also get a quite nice dose response curve. So more treatment, people get better at naming. Okay, so we have really nice evidence that this kind of treatment improves naming. And using the sort of logic that words are the building blocks of verbal communication, what we would expect is if word retrieval got better, including on generalization items, then we should see improvements in discourse, in connected speech. But it turned out, in a paper this group published last year, this is not the case. Do not see generalization to discourse. And even in discourse measures that are sort of closest to word retrieval, so production of semantic errors and lexical diversity, type token ratio. These are things that you would think if word retrieval got better and it was better in the context of discourse, that these are the measures you should improve on, right? And did not see that so these are all different kinds of time point comparisons, and they all are not statistically different from 0, which is very disappointing, and unfortunately not uncommon. This is a kind of a focused review that Nikki Jersinas, a postdoc working with me, and I have been doing. So this is we tried to focus on somewhat larger studies, so at least 15 participants, 10 studies in recent years, a total over 300 patients. So these are studies that all target naming or word retrieval and successfully improved naming or word retrieval. The semantic feature analysis study that I just showed is one of them. And they also tested improvements in discourse. And what they found, for the most part, is no improvement in discourse. Occasionally, there's some improvement in discourse. But for the most part, these quite well-powered, successful naming treatments do not improve discourse. Now, my first thought with these kinds of results is maybe improving discourse is just really, really hard to do. And it's just not amenable to treatment. This turns out to be untrue. When we look at studies that studies that target functional communication or discourse, it's easy enough to find ones that work. So here's from, again, same time window, 9 studies that targeted discourse or functional communication, total sample over 400 participants, and they successfully improved discourse. They also tend to generalize to naming, although not all of them tested naming. So, I'm not making a strong claim that treating functional communication will improve naming, but I also submit that improving naming is not actually the thing we want to be trying to do. Improving discourse and communication is what we should be trying to do. And since generalization is quite poor, maybe functional communication is actually the better target for treatment. And look, I think that there are legitimate reasons why one might want to use naming as a first step, maybe to build confidence or build rapport between the clinician and the patient or client. So, I'm not trying to say don't bother with naming. What I'm saying is that our priority, perhaps, this is my strong claim here, is that maybe our priority needs to be discourse and functional communication rather than naming. And the idea that naming should or would generalize is not an assumption we should be making. I should say that I don't actually think that this is going to be super surprising or controversial. I'm looking forward to hearing what people think, but I suspect we all know that naming treatments can be quite effective, but tend not to generalize to discourse. If this is sort of a known problem, why are we spending so much time on naming? And I think a big part of it is the lamppost problem, right? We have excellent measures and models of naming. We know quite a lot about the cognitive and neural systems that support it. We have good picture naming materials that we can use for testing it. We have different versions of tests, so we can have a pre-test and a post-test that doesn't use the same items. So there's a lot of research tools and theories available for studying naming, and I think much less so for discourse. And I have a tremendous amount of respect for the people who've been trying to develop those kinds of measures for discourse, because I think that's a very hard problem. But I think that's the problem that sort of psychologists of language like me need to be thinking about. So we need more lampposts. We need to make studying discourse as easy and convenient as studying naming is and treating it. Oops. So stronger theories of discourse and functional communication. Another piece here is cooperation and resource sharing. So, it's still the case that most studies have quite small sample sizes. I think there's good reasons for that. Recruiting people with aphasia can be difficult. These treatment studies are quite resource intensive. I think the only way to overcome that is the cooperation and resource sharing. And I think the C-STAR forum is a nice place to facilitate that kind of cooperation. We also need to be thinking about incentives to do slow and clinically relevant science. I appreciate that I'm saying that from a relatively privileged position as someone who built his career at a time when doing lots of simple picture naming studies was just fine. So we need to be thinking about, if we're going to be telling our junior colleagues to do this kind of work, we need to be thinking about making the incentives align with that. Okay, I'm gonna just wrap up here. A lot of the work that I've done, and I think a lot of people like me have done, is using aphasia as a preparation for cognitive neuroscience research. I mean, there's 150 years at least of history behind this kind of work. But I think the translational pipeline metaphor may not be the best way to think about it, because with all of that history, I don't know that much translation has happened, that much movement along that pipeline. The Pasteur's quadrant might be a better way of thinking about this, where this is for people like me who are basic scientists, but to try to be motivated by a real world problem, beyond just sort of saying that aphasia is a real world problem, but thinking about what is actually the real world problem we're trying to address. In my case, the kinds of real world problems that I've tried to address involve lesion-based prediction, where, at least in my case, I find that lesion size tends to be the best predictor for broad measures. Lesion location might be helpful for predicting subsystems or components, or in fact is, but then there's a question about what subcomponents do we actually care about. Another real world problem is fluency or discourse. Again, these are quite strongly correlated with severity, and not very strongly correlated with at least the phonology and semantic components. For informativeness, we do see a strong contribution of frontal white matter. And then the direction we've most recently been going is thinking about functional communication and strategies, and thinking about test performance on things like CIU and QPA as being determined jointly both by the impairment, the underlying neurological impairment, and the communication strategy that someone is using. I think why I find this very interesting and potentially important is that we cannot, at this point, regrow neural tissue, but we can teach communication strategies. So if we can understand what strategies are effective in real world contexts and whether they're sort of idiosyncratic to particular individuals or generalizable. If we can get a good handle on those strategies, then we can try to use that to, as part of our treatment approaches and improve the functional communication and address that real world problem with aphasia. And with that, I'll just say thank you and acknowledge all the brilliant people that I've had the pleasure to work with, and funding from the John Templeton Foundation and the NIH, as well as the various institutions that we've worked with.
Perfect. Thank you so much, Dan, for a really wonderful presentation. I don't think we have questions in the chat box at the moment, but we do have a question starting in the room. So I think you can speak up, William.
Okay. Yeah, hi, Dan. This is William Matchin. Can you hear me okay? Okay, great. Yeah, I don't think we've ever met actually, but I admire your work and I greatly appreciate this talk. I feel like you're hitting a lot of nails on the head here in terms of the translational questions. And as someone who's like a cognitive neuroscientist, I think I see things similarly, although I like my questions, right? It's an interesting and tough sort of thing to think about. But I have a few thoughts, but maybe just one to focus on is, I agree about the lack of sort of translation from a lot of the basic science aspect of this. But what about, the Wernicke model, Geschwin, Lichtheim, right? Like you could argue that that model was wrong, or maybe it wasn't effective in the way that it should have been. But certainly it was a very influential and leading model for clinicians in terms of diagnosis and treatment. So do you think that that's a sort of counterexample to your point at the end, that this actually was a sort of theoretical model, as a sort of basic science question of how language is organized and what syndromes should follow from damage to different centers or disconnection, but that was at least extremely influential in terms of the clinical field. So do you think that's a counterexample, or do you think about that in a different way?
That's a fair question. And thank you, William. I don't think we've met, but I'm also a fan of your work. I don't, I think the honest answer to your question is that I don't think about it very much. And the reason is that I don't worry that much about whether the research direction that someone took in the 1980s was correct or not. That certainly they were influential, and I think certainly set the bar or set the agenda for a lot of clinical work. I mean, I think there are downsides to that. I mean, we know that the diagnostic procedures for that are based on the Geschwin model are quite problematic. We get a lot of people with what appear to be mixed aphasias, or unclassifiable aphasias. Instruments disagree on what type of aphasia a particular patient would have, and there's other approaches that are maybe more effective. I think maybe the fluent non-fluent distinction that has dominated the field is not that great. I think, but I'm not like, I don't want to sort of dump on people doing work 45, 50 years ago. I think the more important question is what we should be doing now. And so that's sort of where I'm oriented with this kind of stuff.
Thank you. I could probably talk with you about this a lot, but I have separately just a kind of like random question. Just, in one of the Lesion-Symptom mapping studies, you talked about lexical syntax, and you sort of referred to this as potentially like a control network. I mean, you did have it looked like inferior frontal gyrus pars triangularis, right? Which, many people have highlighted as a syntax related system. So I don't know if that's just something you think is not the right for this particular measure, your lexical syntax sort of factor, but I was just curious about that.
I think as it turned out, I understand what you're referring to, but I actually think it's not IFG. I think we had that result. It overlaps minimally with IFG.
Yeah.
have a question in the chat. I don't know if you can see it, Dan, or if you want me to read
Yep,
it out.
I see Will's question.
Right. So I'm going to read it out just for the audience.
Mhm.
It's not that, like you, I'm convinced that we need to move beyond treatments that target only naming of individual words. Do you see any potential role for treatments focused at the sentence level in moving the needle for functional communication?
I think that's an open question. Um, my intuition, honestly, is that a sentence level is also not the right target because I think that the strategic elements are more important. But maybe the sentence level is the right level to work on communication strategies, right? So, um, if we're thinking about communication contexts, are things like you need to order something at a restaurant. Actually, maybe an order is not more than a sentence. So maybe the sentence level is right from that perspective. I think um, what I would argue for in a is that the sentences need to be oriented towards communicative functions rather than things like getting the grammar right.
Right. So I Will asked an excellent, this is a question I was also sort of thinking about in a vaguer sense. So I'm glad he asked that. And so to me, it seems like there's an implicit assumption in your talk, in your answer here about plasticity, right? It seems to me that what you're saying is there's really not plasticity happening within the linguistic system. Therefore, you have to go outside of that. You can't think of repairing the system that's damaged. You just need to think about adaptation to a sort of permanently disabled linguistic system. Is that correct?
I certainly think there's plasticity, and I can see why that implication might have come across, and I will try to correct it. Um, I think the plasticity that we need to be shooting for has to be more closely aligned with the function, the communicative function. So I think a lot of times when we think about plasticity, we think about things like, rebuilding the semantic networks or, improving word retrieval. And I think that kind of plasticity is not the right target. But I think, you know, there certainly is plasticity. We just need to target it to the functional domain, if that makes sense. So I feel like I'm looking
Like, I
out.
guess, yeah, just to be maybe a little pedantic, I mean, if it were the case that there was substantial plasticity within these linguistic systems, it would seem to me kind of shocking that that wouldn't lead to translation to some communicative outcome, right? So
Yeah,
the fact that it doesn't, to me, is the implication of what you're saying that they're really. So you see what I'm saying? Doesn't it seem weird to
yeah.
say that if there's a lot of plasticity in lexical semantic processing, that somehow just wouldn't lead to translation? You know?
Yeah, no, the answer to that question is the curse of specificity, right? So the issue is that in cognitive training in general, generalization is extremely poor. And so when you look across domains, right? So you can practice the end-back task and you will get better at the end-back task. And some measures of working memory might improve, but your ability to perform in almost any other task will not. Right. So I don't know if we want to think about that as plasticity or learning, or if those are if the same or different. But you the issue is that you can train naming. Naming will improve. That's a type of plasticity, but it's not going to generalize in the same way that most cognitive training things don't generalize. Chess experts tend not to be better at anything else. Musicians are not generally better at anything other than music, right? So this kind of specificity of the training is a pretty common problem.
But don't you think that's interesting in the sense that, like, as a second language learner or as a child, if I train you on vocabulary, like, I in second language acquisition, I'm not an expert on this, right? But I'm assuming that like doing your flashcards and vocabulary will translate to communicative improvement, right? I mean, that seems to me a sort of a strong effect in that domain. But it's when you look at aphasia, that you're not seeing that. So to me, it's not that it's that general of a problem. It's more specific to the effect of brain damage, and therefore neuroplasticity is not actually happening.
Yeah, so we'll put in the chat what I was just about to say. Memorizing words in another language is actually not super helpful for second language learning. And as a university where we have a lot of international students, I can say we have students that have extensive vocabularies in English and cannot have a conversation in English. And in a sense, that's sort of the problem that we're talking about here, is that someone can know a lot of words, but still actually not be able to say them in the context.
The puzzle. There's maybe this is my last point, right? That you would never tell a second language learner, don't do your flashcards, don't learn vocabulary in isolation, right? I think the argument would be that it also requires another element, but not that there is not a substantial contribution from the vocabulary training.
I mean, there are people who do say that, like that say, actually, if you want to learn another language, you just go and do it. Just go into the place and just try to work it out. And I say that, I mean, I'm not the best example perhaps, but I am a second language English speaker, and I don't think I've ever done an English flashcard in my life. And like my family showed up in the US just winging it.
I could talk about this forever, but there's some other questions.
Dorian had a question.
So we have one question from Dorian. Let me read it while you're reading it for the audience. Hey Dan, great work as always. Have you and others in the field done work to predict multivariate profiles of symptoms or the effect of a treatment on a comprehensive profile of symptoms rather than individual aspects of language, motor, etc.? The language, motor, etc. systems. This would be more to move forward in the x-axis of Pascal's quadrant.
That's an interesting question. I'm not aware of work that approaches it in a multivariate way, in the sense that people will use sort of composite measures. So, the NIH stroke scale is a composite measure of multiple impairments, but I wonder if there's some value in actually treating it as a multivariate outcome. That's an interesting idea. I'm not aware of work like that.
We'll jump in maybe, and I have a follow-up question, but to Dorian's point, we do have some work in that area that suggests, and including a recent publication this year that suggests that if we map in a multivariate fashion lesion data from patients with left hemisphere damage and their multivariate language assessments based, in this case, on the WOP, so including simultaneously subtests in naming, repetition, auditory comprehension, and fluency. This work suggests that there is, similar to what you showed earlier in your talk, that there is a large amount of variance is associated with sort of a general lesion size factor. After that this work applied partial least squares regression, which allows sort of to assign variance to a component and then explore the residual variance. I think consistent with what you talked about earlier, we found that after accounting for this lesion size overall factor, that there were some more consistent or more precise lesion patterns associated with each of these measures, except for the measure that was most heavily weighted in fluency or in speech output. That was mostly accounted for by lesion size. And I want to tie that in with my question, which is kind of a broad scale question summary of your talk. I wonder if we think about clinical lesion symptom mapping as a reality, as a tool in clinical practice. I wonder what's your view on really what should be the outcome measure? What is the gold standard that we should be focused on as from a statistical standpoint to use in the lesion symptom mapping clinical adaptation? Does that make sense?
Yeah, I think there's um, two sides to that. One is what should we be using as our predictors? And I think we need to be taking lesion size very seriously as the kind of baseline predictor. Um, and then the other question is what's the outcome measure that and I think this is closer to what you were asking. What's the outcome measure that we should be using? Um, my take on it is we sort of already know that large scale outcomes like aphasia severity are probably going to be very strongly related to lesion size. And I think squeezing more variance out of it at the expense of computational power is not that helpful. Um, in part because conducting sophisticated imaging protocols acutely is not really going to happen. So, if I need to collect 45 minutes of structural diffusion and resting state data in order to get 10% more variance in my prediction, like that's not, I can't see that happening clinically. Um, but what I think we can try to do is if we can understand what the components of functional communication and discourse are at the level that we understand naming, right? With naming, we can break down into semantics and phonology and articulatory control and all of these kinds of finer grained understanding. If we could break down discourse and functional communication in that way, then I think we would have better targets for prediction. I mean, right now we can use, the kinds of measures that I talked about with CIU and QPA, and there's functional communication measures as well. And we're doing some of that work in my lab now. Just don't have results to share with you yet. But I think we will make even more progress if we can understand functional communication with the level of detail that we understand naming.
But don't you think that lexical retrieval and sentence construction should be some component of functional communication? I mean, they have to by definition, right? They're saying words out loud. Therefore, lexical retrieval has happened, right? So that has to be a component of functional communication.
Um, yes and no. I think that we've placed too much faith in this kind of componential view. I think the the correlation between lexical retrieval and functional communication is low enough that maybe that's not the right way to think about it. That's my more out there claim. I appreciate that this is it feels crazy to say that. But I think actually maybe it's not it's not that word retrieval hasn't happened. Like obviously it has, like you said. It's that improving word retrieval doesn't seem to improve the other thing.
That there's many, are you saying that there are just simply a lot larger factors or just many other factors involved in functional communication?
I guess what I mean is in a treatment context, I don't think it's the active ingredient. There's a question in the chat from Grant.
Yes, I don't know if let's take that question, I think, and then we're at the end of today's allotted time at least. Let me read through it while you're reading through it and composing your answer as well. So Grant says, hey Dan, that was a great talk, thanks. What do you think is the low-hanging fruit for situations where access to neuroimaging data could someday impact how aphasia is treated? For example, what are the decisions that an SLP might have to make where behavioral testing isn't enough and a good model of neuroimaging data would help? Is that type of thing an end goal for this research?
Yeah, so here's I don't know if I would describe this as a low-hanging fruit, but I think it is a fruit, which is that aphasia, as I think we know, aphasia is very common acutely and recovers sometimes for some people. That's the part that's variable. And so in the acute stage, the behavioral measures are less helpful because sort of like a lot of people have reasonably severe aphasia acutely. And so that's a situation where prediction might be helpful, like lesion-based prediction might be helpful, is if we used acute data. I think the challenging part is actually using clinical data, right? So, in the first couple of days after a stroke, the kinds of protocols that a lot of us use are not appropriate. And I know that there are people here who've done acute stage scanning that's very impressive. And maybe it'll become more common, but I think at this stage it's not. So a situation where the behavioral measures are not very predictive, that's one place where the neural measures could be more predictive. The other piece where I think it's potentially helpful is if we can better connect treatment strategies, right? So I think like your question is saying, right? If we're thinking about what are the decisions that an SLP is actually making, because I think a lot of the stuff that we predict is not actually what, right? So like I have a predictive model of speech perception versus speech production, but I don't think SLPs are actually choosing, do I want to treat speech perception or speech production? And even more than that, I'm talking about the impairment. I'm not talking about which treatment is going to be effective for somebody. So I think this is a very high-hanging fruit, whatever is the opposite of low-hanging fruit. But to be able to say, here's the impairment, here's the lesion, here's the kind of treatment that's going to be effective for this person. I think that's really the sort of the target that would be really brilliant to hit. But I think we're really far from that.
Perfect. Thank you so much. I think this is a good note to end today's talk. Even though this discussion I know could go on for a long time and will in a different format. Well, thank you so much.
Well, maybe I'll see you guys in Europe in 2026.
Absolutely. Thank you so much for a really wonderful talk.
Thank you for having me.
I look forward to seeing you and everyone again in 2026 for another C-Star lecture. Happy holidays.